So, dear colleagues, ladies and gentlemen, it's with great pleasure that I'm going to talk to you about how sex and gender affect kidney transplantation. So there are potential differences between women and men, and they may occur at different levels. One is the access to a transplantation waiting list. The next is access to transplantation once waitlisted. And then the third is outcome after transplantation. Just as a reminder for all of us, there's an important difference between the terms sex and gender. While sex is a biological attribute that includes anatomical, endocrine, or genetic traits, gender encompasses social, cultural, and psychological identities and behaviors. In short, every cell has a sex, while individuals generally have one gender, and this is with the exception for gender diverse persons. We know that women are more likely to be living donors than men, and this disparity has actually been seen in parental as well as marital relationships, and it might be explained by a higher level of empathy in women, and also because the father or husband is often the family provider, so there might be economic factors as well. Also, there are more deceased donors that are male than female. We know that women show more willingness to become deceased donors. And with regard to the predominance of young males as deceased donors, this is probably reflected by the higher rates of traumatic death among young males, whereas female deceased donors tend to be older, and the most common cause for them is cerebrovascular accidents. But overall, there is a sex imbalance among donors and recipients, and that results in women giving more often than receiving. When looking at access to transplantation, we can break this down into access to living donation, access to deceased donor waitlisting, and access to receiving a transplant. You can see here that the absolute numbers of patients on the waiting list for kidney transplantation show sex imbalances, and this is showing the data for the United Network for Organ Sharing, UNOS, as well as from Eurotransplant ET. And you see that on the waiting list, there are fewer women, 39%. And this is very similar for the patients transplanted. There are fewer women, 40% for UNOS and 38% for ET that are transplanted. And one of the reasons for these different prevalences are underlying diseases that lead to end-stage renal disease, but there are other factors that contribute, and I'm going to discuss them. So this is showing the several influencing factors for the different stages that a patient experiences once end-stage renal disease is reached. And when and whether a patient is listed for transplantation depends on, for one, the underlying disease, the immunological constellation, whether there is sensitization. In women, this would be often pregnancy associated. There is often differences in the burden of comorbidity. It's important how the physician feels about the patient, but also the patient's self-esteem and self-assessment. There are socioeconomic factors and cultural factors. Similarly, the time from listing to transplantation depends on the progression of the underlying disease, again, immunological constellations, and again, also sensitization. Success of transplantation depends on sex match, organ mass, recipient age, again, immunology, sensitization, and also adherence. Sex and gender-based disparities in access to waitlisting and transplantation were already reported in the late 80s, and they showed that women have lower access to kidney transplantation. And this is an early study that showed disparity in waitlisting, which is depicted here, but also in transplantation rates. And this unpublished data from my own group showing a meta-analysis of more recent studies shows that mostly the reported disparities are with regard to waitlisting rather than transplantation. That is probably due that the newer studies adjust for confounders, including PRA status, comorbidity, and underlying disease. And several studies, as I said, highlight the preponderance of males entering the waiting list for kidney transplantation, but that doesn't necessarily mean that that the male preponderance on the waiting list implies a disparity. There's no high quality studies that have compared waitlist access between transplant eligible men and women with end-stage renal disease. Sex differences in transplant eligibility may exist due to differences in primary disease or comorbidities. And we already know that there are more men than women with end-stage renal disease. So we really, given the knowledge that we have at this point in time, we need studies that assess whether men and women have equal access to deceased donor kidney transplantation. And from what we know so far, or the most studies we have on this topic were performed in the context of the US healthcare system, and most of the authors concluded that socioeconomic factors may have explained differences. There is some challenge to this economic explanation by European studies with a more universal coverage, for example, from France, where sex differences were also reported for waitlisting despite a more universal coverage. On the other hand, there were studies from the UK where the differences in access to waitlisting could not be shown, and these studies had actually included only a minority of patients that were older than 65 years or had completely excluded them. And this brings me to my next slide that shows that age is important when looking at access. And this study, using data from the US RDS and UNOS, demonstrated an age effect with older women above the age of 65 having the least access to transplantation. And that was even in the presence of the same comorbidities, women had less access to transplantation when compared to men. And looking at the other hand of the age spectrum, it's important to note that sex disparities do also occur during childhood, as the study from the ESPN ERA EDTA registry shows. And you could see here that male recipients were transplanted more often when compared to female patients. And the authors showed that that this difference was due to girls having less access to preemptive transplantation when compared to boys, and this difference could not be explained or only partially explained by underlying disease, time to first contact with the nephrologist, and progression rate towards end-stage renal disease. Potential reasons for reduced or delayed access to transplantation for women versus men include a lower probability of discussing transplantation as a treatment option with women. And as shown here, fewer women actually complete their clinical workup needed for transplantation. And this study showed that Hispanic men, shown here, were best in completing their clinical workup, while non-Hispanic white women turned out to be the worst. Another aspect might be that physicians may assess women's health differently. And this is an analysis of the US RDS data showing that a greater BMI, greater than 25 kilogram per square meter, was associated with a decreased likelihood of getting transplanted into women. This is shown here. Whereas a BMI between 25 and 35 kilogram per square meter in men facilitated transplantation. Another issue is that women more often have health-related or psychological concerns about transplantation, as seen in this table. Women often feel that they're too weak to undergo transplantation. They feel that they are not the appropriate candidate. Then they have psychological concerns that they feel afraid of the operation. They also have trouble in asking for a potential living-related donation, which you can see was also asked as part of this questionnaire study. This is a study now that looked at outcome parameters, and it's based on the US Transplant Scientific Registry and was supplemented with end-stage renal disease data in the US Renal Data System. And the study sample consisted of 29,000 female and 44,000 male renal transplant recipients receiving a first renal transplant. And these patients were followed from transplantation date until graft loss or death, or until the study ended, which was in this case at June 30th in 98. And you see in the left figure that death-censored graft survival for female compared with male renal transplant recipients, and there was no significant difference in death-censored graft survival. But there was a tendency in women to show more early graft loss, and this can be seen here. When you look at the upper table here, you see the results of a logistic regression analysis on demographic factors influencing the risk of acute rejection. And in female recipients, as compared to male recipients, the risk of acute rejection was 10% higher during the first 6 months after transplantation. While looking at the lower table, where the authors analyzed the risk for chronic allograft failure, they showed that female renal transplant recipients were protected actually from chronic allograft failure as opposed to male recipients. The problem of this publication is that it comes from an older transplant area and that it doesn't show mortality data. It's just stated that, and I quote, patient survival and non-censored graft survival were both significantly better in female as opposed to male renal transplant recipients, but the magnitude of this result was not clinically relevant. When we look now at data from Beth Foster and colleagues investigating changes over time in mortality rate and in age, sex, and race standardized mortality ratios relative to the general population in transplant recipients aged below the age of 21, they looked at almost 19,000 patients who received the first transplant at an age, as I said, below the age of 21 years, and for which data were recorded in the US RDS. There were 2,713 deaths over time, and they followed these patients up for almost 9 years. And even so, sex differences were not the primary focus of this publication. The authors found that male recipients were at a significantly lower risk for both cardiovascular as well as infection-related mortality, and this can be seen down here. And also there was a trend. This can be seen towards a higher all-cause mortality in males versus females. This did not reach statistical significance. The p-value was 0.06. And the discrepancy to the myocretia data is explained by the use of standardized mortality ratios, comparing the risk in the transplanted patients with the risk of the normal populations. That is a very important difference between the two studies. And this slide depicts another study done by the group of Beth Foster. It's based on almost 160,000 patients from the SRTR. These are first deceased donor kidney transplants between the years 95 and 2013. Median follow-up was almost 5 years. And this study elucidates the complex relationship between sex and kidney transplant survival by examining the interactions between donor and recipient sex and recipient age. And in these survival models adjusted for multiple factors such as race, primary cause of end-stage renal disease, duration of pre-transplant dialysis, donor age, donor weight, recipient weight, and PRA status, the authors show that in the setting of a male donor, this is the upper panel here, female recipients of all ages have significantly higher rates of graft failure when compared to men. This is always females compared to male recipients. And you see that the largest differences were observed in children. This is seen here. And the smallest differences were seen among adults above the age of 45, which is shown here. And you have to look always to the right confidence intervals here, because this is the adjusted model. When the donor was female, only adolescent girls and young adult women had higher rates of graft failure than boys of the same age. And in fact, in the setting of a female recipient being older than 45 years of age, the rates were so in fact, in the setting of a female donor, the female recipients above the age of 45 years had lower graft failure rates than men of the same age. This is shown here. So the biological mechanisms that have been proposed to explain the differences in transplantation outcomes by donor sex include physiological differences in kidney size. We know that the number and size of nephrons is greater in male than female donors, and this may influence graft outcome. Then there are differences in the regenerative capacity between men and women, and the susceptibility towards ischemia reperfusion injury. I have alluded to the fact that after pregnancy there can be sensitization, and this is a very well recognized risk factor for poor outcomes. And there's the presence of male-specific minor histocompatibility, the HY antigens. And this actually leads to differences in alloimmune responses. We know that sex differences in immune responses have been appreciated in other disease contexts, suggesting that sex differences do also occur in alloimmune responses and may contribute to the sex differences in graft outcome. In fact, we have seen in an earlier slide higher rates of acute rejection in females, and this has been also noted in other studies, but requires confirmation, and especially since SRTR data have limitations when capturing acute rejection rates, and other available studies couldn't necessarily show the same effect in kidney transplantations. We know that pharmacokinetics and or dynamics may be affected by recipient sex. Calcineurin inhibitors are substrates of P-glycoprotein and cytochrome P450. And the activity of P-glycoprotein and cytochrome P450 is dependent on sex, and various studies have shown a rapid clearance of cyclosporin in females. And actually, we have, in a very recent study, shown in a sex stratified analysis that there are differences in girls and boys, and we saw that high cyclosporin levels and resulted in higher systolic blood pressure levels in older girls when compared to boys. And for this study, we had analyzed data from the CERTAIN registry, which is a European-wide transplant registry. So to summarize, sex differences in graft and patient survival have only begun to be characterized in solid organ transplantation. Prior studies examining sex differences were inconsistent and difficult to interpret, mainly because the vast majority of studies fails to consider the potential modifying effects of recipient age and or donor age. And another difficulty in interpreting results is that primary outcome is different between the studies. Some studies actually consider death-censored graft survival. Some use graft failure or death, including death with graft function. Others use all-cause mortality, and then others even use a composite of all-cause mortality and graft failure. And the latter is especially important because the mechanisms underlying the association between sex and graft failure may differ from those underlying the association between sex and death with graft function. And indeed, these associations may be in opposite directions. For example, women may have a higher risk of graft failure due to rejection than men, but are at lower risk of death with graft function. So I've outlined the need for and the benefits of studying the influence of both donor and recipient sex on graft outcomes. So far, the vast majority of the published studies are sex and gender blind. They ignore the potential importance of sex and gender-based differences in physiology and behavior. And we need to implement changes at every step of the research process to steer towards meaningful and systematic incorporation of sex and gender into research. The North American National Research Funding Agencies are aware and have put forward clear guidelines on the inclusion of sex and gender considerations in research that are needed. And I encourage you to check their websites. And the Canadians are especially fortunate, as the Canadian Institute of Health Research established the Institute of Gender and Health with its director, Dr. Tannenbaum. And the mission of this institute is to foster research on the influence of sex and gender on health, but also, let me quote, to ensure that knowledge generated by our community is translated into improved policies, products, services, and systems that support better health for everybody. I would also encourage you to check out the following reviews that address sex and gender issues with regard to transplantation. This one has very recently come out and is unfortunately not available as a PDF as of now. And with this, I would like to thank you for your attention, and I also want to express my sincere gratitude to the Ministry of Science and Culture of Lower Saxony for their support of our studies on sex and gender in renal transplantation. And I finally would like to thank my collaborators within this project for their ongoing support. Thank you.